Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring them on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments. So I'm here with Jared Mort, the COO of Curus Health. How you doing, Jared?
Good. It's an honor to be here. Thank you.
Well, I want to touch on real quick. You had quite the journey to get here. You came in from outside of Dayton, Ohio. You said it was Beaver Creek, I think.
Yes, sir.
Yeah, so,
Beaver Creek.
But you were supposed to be here yesterday, and that didn't happen. So
Mother Nature had other plans.
Yeah,
Yep.
So you had to stay the night. Fortunately, you were in your home
I
base,
went home,
right?
slept in my own bed. My wife was happy about that.
Yeah,
I know. And I'm here today, and I really appreciate the time.
Well, no, and I appreciate, I was telling you off camera that you're my first Ohio guest. So I appreciate you helping me checking off Ohio. I hope to get to all 50 states. Got to find somebody in Hawaii, though, ultimately to draw from eventually. But
that shouldn't be hard to do.
Yeah.
Or you can go to them.
Oh, now we're talking, if they'll foot the bill.
Right.
So, Jared, today we're going to talk about clinical care coordination, or yes. I think you all even called it maybe clinical care orchestration.
Orchestration, right.
So that'll be the bulk of today's conversation around Curus Health. But before we do that, my flow is always to get to know you first, to get to hear your story, personal, professional. Kind of want to hear, bring me up to current day, but give me the brief version of your biography, if you don't mind.
Sure. Well, like most people, I was born.
And then I showed up at Curus. Yeah.
Yeah, exactly. I'm from the Dayton area and grew up, graduated high school, went to college to become a nurse. Did ROTC for 3 years, joined the Air Force after that, and I became the jack of all trades but master of none.
Okay.
Med-surg nursing, pediatrics, oncology, and then I got picked up to go to flight school and become a flight nurse.
Okay.
So we took care of all kinds of wounded, sick, injured. We were on fixed-wing aircraft, and we got stationed at Yokota, Japan, which is outside Tokyo.
Okay.
2 small kids in tow, and here we are in this strange country, and it was great. A wonderful experience, and some of our friends had never left Ohio. Mm-hmm. So when I got the assignment, they're like, "You're gonna die, dude." So we had a great time out there, and then I ended up going to teach flight school 4 years later. Did that for 4 years, and then I got picked up to go become an advanced practice nurse. So I am a clinical nurse specialist. It's like a nurse practitioner, but instead of seeing patients in clinic every day, I'm in charge of overall outcomes.
Okay.
So whether it's running a diabetes clinic, congestive heart failure, you kind of get the idea.
Yeah.
And so I did that for the last 7 years of my career in the Air Force. And I was in charge of the inpatient outcomes for the entire AFMS, all Air Force.
Okay.
And I became the medical surgical consultant to the Surgeon General for my last 4 years.
That's pretty cool.
And that was really cool. A lot of stress. Yeah. But in some ways, that was the pinnacle of my career, And then they were going to move me to the Pentagon to write guidelines, and I decided that going to the Pentagon for 3 years alone without my family was not in the cards.
Yeah, because you said you had 5 kiddos, correct?
We have 5 children.
Yeah, I can imagine. Yeah, and so having to move around, obviously multiple stops throughout your career as well. But you decided at that point. I think you said you were 20 or 21 years in.
Just shy of 21.
Just shy of 21, and is the 20-year mark is the quote unquote retirement mark, if you will, or how does that work?
It's changed in the last few years, but yeah.
Okay.
When I was in, that was it. You were good at 20.
Yeah, you're good at 20.
So that was your goal. When you first come in the Air Force, it's a calling. Mm-hmm. You cut me, I bled red, white, and blue. But at about the 10, 12-year mark, it was really a career choice.
Okay.
And it served well.
Well, it served well, and obviously the experiences you've had, you got an amazing amount of education, on the job as well as in an academic setting, and obviously prepared you, I think, for the role at Curus that you have now.
Yeah.
But talk to me a little bit, if you don't mind, The transition, if you will,
Yeah.
from the military world to the civilian world, what that was like after 2 decades of service.
Right.
I'd like to hear your experience around that.
We were talking about this earlier over coffee. It's, especially as an officer in the Air Force, it's go, 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 do better, do better, do better. Nothing, your plate's never full enough, right? And it's all about the mission, which it should be, but it's just nonstop chaos and tension and stress. And, when you're younger, you kind of thrive on that. But as you get older, it's more, okay, what really are we doing here? If that makes sense.
Yeah, absolutely.
And so transitioning out of that, it took me a while, 1.5 years or so, to that everyday just drumbeat to what's really important. Can this wait till Monday?
Yeah.
And then really hone the skills in on what is truly life or death. So the clients we have, for example, I think that's really helped me focus on them as individuals and their families and the journey they're going through. So
what I read, and listening to hear you just say that, I've read before that there's people can get addicted almost to the stress. Right? It becomes your baseline has to be so high for you to feel normal that it's almost difficult to relax. I suffer from that as a type A person myself. Totally different setting of what you experience in the military. But I think I understand the notion of like, it's hard to relax sometimes.
Oh, yeah.
And
if not impossible.
If not impossible. So did you find maybe that was one of the more difficult parts is just
definitely.
being able to be relaxed? Yeah.
And it took me a long time to where I could just, hey, it's Sunday. We're at home from church. And I'm not going to do anything but watch football. Yeah. It took years to get
But
there,
it's almost kind of nice too, because there's a point where you feel you earned it, right? I mean, like there's a, and maybe it's hard to say.
My wife hears
that.
this, she's going to say, "Oh
no, hey, I'm in support of you. Tell her to give me a chat." But so let's move into a little bit about a couple of fun facts about you that you shared with me that I thought was really cool. Is you were jokingly saying you love to take things apart. It's kind of the putting them back together that not quite your skill set.
Challenge, right?
You're a tinkerer, right? You love to see how things work. But Virginia was joking when we were having the call the other day that not everything goes back together exactly, right, or at all, right?
Yeah, I'm that guy. I want the challenge. I love home improvement. I'll work on cars to a point. And I find myself, I get in trouble sometimes, taking calipers off a car, and I'm like, wait a minute, what did I just do?
Yeah.
And then 10 trips to O'Reilly's to get advice from those guys, you know. But when you get it done and it works, you're like,
sense of accomplishment too. But you said you also read like clinical literature for fun. Which I wanted you to touch on that because I'm like, wait, that's actually what you do, as your
I do a lot
pastime?
of that.
Okay,
absolutely. We were just talking about the Cochrane database, right?
Yeah.
So I'll go look at meta-analyses and read it through and what type of research was it, what's the recommendations, what classification. And my wife kind of was like, "What? That's fun for you?" I'm like, "Yeah, I can use this in my job."
Well, I guess so. Yeah, obviously, if it supports your job, it makes sense to do it. But I mean, it's also, if most people would look at it as fairly dry in nature in terms of the subject matter, and
well,
not to you.
See, my training as a clinical nurse specialist is to take the research that's been done and apply it at the bedside.
Okay.
Right.
Yeah.
So to me, this is great.
Yeah.
It's like a freebie. I don't have to do the research, but I certainly can apply it and help somebody.
That's
so
awesome.
But I think I was telling you, my favorite pastime is doing whatever my kids are doing.
Okay. Yeah, and your kids are active in sports and band and all sorts of
exactly. The Scouts and so I'm not like a helicopter dad, but I want to hear what they're listening to. I want to watch what they're watching. Video games, I want to see, what are
well,
they
you said you get into
to?
the video games, don't you, a little bit yourself?
Yeah.
Like, what's your favorite game you're playing right now?
I got into Fortnite with my son.
Okay, yeah.
And I love getting on with all his friends. And they're like, "Your dad's so cool, man."
That's funny. Man, Fortnite is like so over my head. I know a lot of kids play, and I think you can sink a lot of money into that game too, right? Where
Any
you're buying
game these days, you can,
it used to be you buy a game and you owned a game. Now it's like the game's free and you have to pay for a whole bunch of crap while you're in. Anyways, don't get me on that subject.
So all the good players, that's because they're rich.
They're rich. Yeah, that's because they're rich. Well, so let's get into Curus a little bit because I think it's going to be a subject that I have not dived into or dove into really in much detail.
Yeah.
you're going to educate me, I think, a lot around kind of that 5% cohort, if you will, of the folks that are either the worst clinical conditions or the most chronic of disease states, and that's where Curus helps and intervenes. And so I want to hear about that. But I read on your website that you guys consider yourselves like a total life concierge. Maybe that's morphed a little bit. Maybe that's a legacy term. But I want to hear from you. What do you mean by that?
So originally, our founder, Mark Schlussel, that was the name of the company. Total Life Concierge.
Oh, really?
But we do business as Curus. So he said that in his first sales meetings, he would spend more time explaining to them what TLC meant instead of tender loving care.
Yeah,
that he couldn't even get to the concept of Curus.
That's funny.
So that's where that comes from. And, you know, that the original company was designed really for executive care.
Okay.
You know, if you're spending hours upon hours a week scheduling your doctor's visits or for your kids' appointments or whatever, we would do that for you. Thus, you could go back to work and, you know, spend that time. Then we realized that with the self-insured business especially, the adverse select are the people that really needed the most help.
Yeah.
And that's where we kind of got into that niche.
Well, so let's talk about adverse selection, or people that adverse select a plan. I kind of have in my brain what a definition of that is. I want to hear your definition, and maybe I'll pepper on mine. But for somebody that doesn't really hadn't heard that term or what that means, what do you mean when you say adverse select?
Yeah, it's fairly a newer term with the industry, and there's a couple of terms like it. But in our wheelhouse, an adverse select member is one that is very sick, very costly in the plan. It could be an employee, their loved one, whoever. And that could put that entire plan in jeopardy.
Okay.
So for, like we were talking, a smaller company, maybe 100 lives, 200 lives, 1,000 lives maybe, one of these members could sink the plan. Mm-hmm. And so what are you going to do proactively to show the carrier or stop loss, right? Mm-hmm. What are we doing to help lower the costs?
Yeah.
Or plan for the long term.
Right.
You know?
Yeah, because it's not all, you can't always divert that risk. You can't always get rid of the risk, if you will, because there are certain regulations, of course, about whether the member can be on the plan. And some risk is just ongoing, like the common one we always point to, a hemophiliac, that's simply just ongoing.
Hemophiliac, or a lot of these autoimmune disorders.
Okay, yeah,
like
give me
these
an example.
Expensive drugs and
What's an example of an autoimmune?
Rheumatoid arthritis.
Okay.
That's a good one.
Yeah.
We see a lot of that. And the costs aren't ever going to go down with these drugs. They're only going to go up. But we can help manage the overall cost. Okay. Right? And then help that plan the next year. Hey, we know they're going to be $250K or whatever. But if we can stop the inpatient admissions, we can stop the ED utilization, the urgent care, and get them to their specialist primary care doctors, that really does help drive not only the cost down, it helps their outcomes, gets them back to work. So we're talking hard and soft costs. Yeah. And then ultimately helps that individual and their family.
Yeah. When I look at the adverse selection too, because there's the employer's perspective, right? I guess the terminology suggests that they're adversely selecting against the plan, meaning like maybe I'm a sick member, at least that's the terminology I would use.
You could read it that way.
You could read it. So especially because I've been in the broker world where it's like, hey, maybe we're giving two options to members. One's a high deductible health plan with an HSA, one's a more expensive but richer plan in a PPO. You would have potential for adverse selection for the folks that are the most likely to hit their maximum out of pocket and be those high utilizers. The adverse selection is they're paying a little bit less for in premium. They know they're going to blow through their out of pocket, and maybe they're also adversely selecting that plan because it's cheaper than their own plan or a spouse's plan, right? And so that adverse selection can kind of go both directions, but either way it suggests somebody's likely going to cost the plan a lot of money.
Exactly right. Very good.
Well, yeah.
You're hired.
I'm hired. Good. I got that job.
So that's why we hired people like Virginia, that you mentioned her.
Yeah, yeah.
She's an expert with all reinsurance stop loss, so she's our expert. And that's exactly, that's what she would have said too. So
when I want to get, you mentioned to me too, like we're talking high cost claimants, and you said probably the top 5%, if you will. That's maybe a gray area in the actual percentile. But like what percentage of a population of a plan on average would fit into the categories that you guys ultimately could be able to address?
That's a great question. So we go by the 550 rule.
Okay.
It's about 5% of everybody that's costing the plan 50%. Easily, right? And like you said, it could be 3%, it could be 8%, but 5 is a good average. Okay. And then the clients that we see the most of I call them patients, but the members, we see a lot of cancer. We see autoimmune. We see hemophilia. I know there's not many in the nation, but again, you get one of those on your plan, We see lots of renal, end-stage renal disease going into dialysis.
Okay.
Mental health is on the rise, post-COVID.
Yeah.
And that's another post-COVID. We're dealing with quite a few clients that have a post-COVID that just can't get a true diagnosis.
Okay.
And so we lead that.
So they're in and out of the system with no real clarity about what actually they're suffering from or conditionally?
Correct.
Okay, interesting.
And then they don't know to go to a certain specialist. They don't know who to go to, where, if it's covered in network. And that's one of the big things we do.
Okay.
Is we pull all that together, get them in front of the right doctors. If it's 2, 3, 4, 5, which we've done, and then we get them that final diagnosis. And we do that through our virtual company. And if possible, then we get them ahead of the line at a center of excellence, like a Mayo, because I think there's 35 or 40 different clinics now that can diagnose post-COVID.
Okay.
But it's over a year waiting list.
Really? Over a year waiting list?
We can do it in network, virtually with them.
Okay.
And get that diagnosis and then get them on treatment.
That's right. When you were telling me you guys aren't case management, I think
No.
When I was trying to put you in a bucket, and I think I was asking you if you guys suffer from a similar issue, and I don't call it an issue to mean it's a bad thing, but PlanSight, my company, is in this category that's still being defined in real time by the marketplace of what's it called. So I was trying to bucket you in disease management or case management, and you were quick to say, well, that's not exactly what we do.
Right.
So how would this differ from a case manager?
Yeah. Thank you. That's the $1 million question.
Okay.
And when we have our sales meetings, we're always trying to get that message out there.
Yeah.
The simple answer is, and I know a lot about pop health, population health, and HEDIS measures, and so I know what disease managers do. It's very important what they do, not for that 5% because it's too late, right? And then case management will get involved only to an extent.
Okay.
I made a phone call, I talked to them, they have a doctor's appointment, they put their note in, they did their job. But what Curus does is we get in there, we're like a medical SWAT team. Think about that.
Okay.
So you get newly diagnosed with a cancer. Our number one cancer right now is stage 4 metastatic breast cancer.
Okay. Number one in terms of frequency?
Yeah,
okay.
our number one.
And why do you think that is?
Couldn't tell you.
Okay.
I wish I could. So anyway, they get this diagnosis, and they're already costing the plan a lot of money. And they give us a call, the employer or the benefit advisor, producer, whatever, consultant. And we go in there, and it's a fixed fee. Okay. So we don't charge hourly like case management or some of these other companies. And we go in there, and it doesn't matter if it's 1 phone call a day, 10 phone calls a day. We get in there, and we get it done for them. Okay. We get them second opinions. We can get them to centers of excellence, like I mentioned. We get all their medical records and review it as that medical team. I was telling you about this. We once we get a new client, we do an initial call. It's like getting a history and physical over the phone. We can't do the physical part, but and then we brief as a team, a medical team, and it's multidisciplinary professionals. So we got our medical directors, we got nurse practitioners, PAs, nurses, and we go through just like they would at the bedside in a hospital. I don't know if you've ever been in a hospital. They come around once a day, and then they go out in the hallway and talk about the case, and everybody hears it. So that's what we do, but again, virtually, and we go over the cases and say, okay, well, what's the current evidence-based practice right now? Okay. Do they have a good care plan that we agree with? And what do we need to teach this person so the next time they go to their appointment or the new specialist, they know what questions to ask, they're prepared, they feel confident? Because most people, you might have the best doctor or nurse in the world, but you go to that appointment and you're diagnosed with the big C or anything that is going to be life-altering. And you go through those stages of anger, fear, grief. And you just don't, whatever they tell you, as soon as you walk out of that doctor's office, you don't remember it. And we're here to take that burden off their shoulders and walk them through the process. Like the orchestration you said.
Yeah, the orchestration, can you conduct the whole thing, it seems like, and you were saying it's not really a coach, but there is an element, it sounds like, of coaching. If you were just going back to what you just described, it's like, I get a diagnosis I don't understand, or it was such a traumatic diagnosis that I just completely shut down and didn't remember.
Yep.
I still have a role to play in my own care, right? Making decisions.
The most important role.
Yeah.
Right?
So I mean, some people might defer all of their care to the doctor. You know, they kind of that authoritative figure where everything, whatever my doctor says, I do. But sometimes people will relinquish their own responsibility, and it sounds like you guys are arming them to be active participants in their care as well.
I always laugh that we're working ourselves out of a job with every client, and that's a good thing.
Yeah.
We do have a lot of clients that renew. All of our care contracts are renewable, but you know, the whole idea is that we train them how to navigate the healthcare system that is so apathetic, and that's probably the biggest win for us is when they can do that.
Yeah. Well, and I want to talk about, you know, I think about the audience a lot of who's listening and who would benefit from this. The perspective of the consultant, I always sort of assume the shoes of them when I'm having conversations like this. So if I'm a consultant and I'm having a conversation with an employer, there's kind of two different dynamics of things they're going to think about. The employer is thinking about ROI in terms of return on investment in actual dollars.
Correct.
But there's also a qualitative ROI to the member and potentially the plan as well, where you would prove better outcomes, quality of life. So how do you balance those two things when you're having that conversation? Because one is money, the other is the actual member's life, right? So there's two different things, two different dynamics there.
Yeah, that's fascinating too, because it depends upon what the company wants.
Yeah.
But we do put together a spreadsheet for everybody. It's cost mitigation, but healthcare outcomes as well. And so you have the quantitative and you have the qualitative, which is sometimes hard to capture.
Okay.
The ROI versus the VOI, right? So did we get them back to work in a timely manner? For example, we have the case I think you and I were talking about, where sometimes it's not about getting them back to work, but getting them the humane treatment and care that they deserve. We had a gentleman diagnosed with really bad cancer, and it was during COVID, and he was from Oklahoma, and they had to transfer him down to Dallas, where he was in a COVID ICU, and he was alone, knew he was dying, in a lot of pain. Nobody was coming in to do anything for him, and I just happened to call him one day to check up, you know, doing my quality control, and he picked up the phone, and he's like, "Jared, get me out of here. I want to go home." He's like, "I can't see my wife. I can't be with my dogs. I can't listen to my music. And, you know, all I hear is beeping, and it's cold in here, and it's loud." And then I know. And I said, "Well, hang on." So I got on the phone, talked to the charge nurse and the attending physician, and within a couple hours, he was on a life flight helicopter home.
Wow. We
set up hospice. They were there to receive him, and he died the next week, but comfortable.
But at home.
At home. Warm with his wife and dogs. So going back to that question, we do save people a lot of money. One story was a hemophiliac. We had him switch to a lactate, which is one of the drugs you can give. And within a few months, he was able to get the necrotic elbow surgery and his knee surgery back to work.
Okay.
$300K we saved just that 1 year in 3 months.
In 3 months. Okay.
Right.
Yeah.
It's tough. I can't promise that for every client. But usually it's a 2 to 3 time return on investment.
Yeah. Well, and so when you think about, and you were delineating the set rate versus the hourly rate, or a percentage of savings, sometimes is a model that I think some businesses kind of hang their hat on. What is it about that set fixed fee that you think is the appropriate way to charge for a service like this?
It goes a lot into the personnel hours and obtaining records. The bulk majority of the work is done right up front. Like I said, that medical SWAT team. We come in, we get control that situation, we surround them with everything they need, and like I was telling you, we walk them through. And after that, it's really how much more are they going to need once we've taught them how to navigate the system.
Yeah.
Does that make sense?
Yeah.
If we charged hourly, I don't know how far we'd get. So it's better
so what is it about
for the outcomes for that individual person to just have a flat fee.
Well, I guess you simply just calculate on average, though, like one case might require 100 hours, one case might require 2, right?
Definitely.
Like you have to kind of factor that in and balance.
You're going to have your outliers.
Yeah, you're going to have your
outliers.
outliers.
One guy's like, "Man, I'm good. You don't have to call me till next month."
Like, Okay.
Well, we will, but or the lady that we've talked to 10 times a day.
Yeah,
you're right. There's outliers.
Yeah, there's outliers.
That's incorporated in there too, but mostly it's the biggest impact for that person and their families.
Yeah. Well, I like that, and I like you sharing. I appreciate you sharing that story. Probably an emotional story to share about the gentleman that passed away at home, but it's like. That's where you get into the quality of life for that person with the last week they had left, right? There's not a dollar amount that you can necessarily associate with that. And if I was that person sitting in that hospital in that cold setting, away from my family would say there's no dollar amount that you could define what it was worth to transport me home. And so it becomes less important about the return on investment, like you said, value. I think VOI, you said value on investment, and there's the humanity that often gets stripped out of our healthcare system, unfortunately. It leaves it where it's a very cold and sterile place.
And the big thing, what you just described, is we are their number one advocate.
A patient advocate, right? I mean, patient advocacy, yeah.
And family advocates, because even after that, sorry to cut you off.
No, not at all.
Their contract had expired, but we still talk to the wife and his parents. Because they're getting medical bills, they don't know where it came from. They're getting debt collectors calling them, which is illegal. And we're like, we got this. Send us the bills. We'll look them over. And do we appeal? Do we send them back? Do you just shred them? And we do that with all of our clients. They don't have to be deceased, but that's one of the things. We go over their explanation of benefits with them so they better understand. And then if they do get medical bills, we're like, okay, let's do this. Put them in a stack. These are the ones you don't know what it is. And then we go through that with them, usually once a month.
Okay.
And help them through that.
Is that something you might go over in a Zoom where you can screen share?
We've done it on Zoom.
Yeah.
We have secure email. A lot of times they just take pictures and send an email and we look it over.
Well, let's go down to, I want to go down to kind of a case level, because we oftentimes will talk big picture conceptual of this solution. Yeah. But then I like to drill down, well, what if I'm an employer investigating this? And I know maybe there's an individual or two potentially that a Curus Health could help me with. I want to talk about the brass tacks of delivery of this model of care. So give me an example. First, let's start with a common disease state that you execute on very, very well. Break free from rising pharmacy costs with EHIM, powered by ProCare RX. Are you working with a marketing PBM or one that owns their own systems and services? EHIM is a full solution pharmacy benefit manager committed to lowering costs through creative formularies and white glove member care. They truly do every service in-house. Year after year, this allows our clients to experience significantly lower overall and specialty drug trends than the industry average. As a manager of pharmacy benefits, EHIM believes in doing things differently by putting people first, working with them every step of the way, from walkthrough implementation to lasting member engagement. Visit EHIMRX.com to learn more about their custom plan designs and lowest net cost savings.
Well, I could keep going back to cancer, but we could say rheumatoid arthritis.
Okay. And so ongoing medication, something like a Humira is likely going to be?
Very likely.
Very likely. Okay. Yep. So we'll just use that as an example, because I always like to draw it to where somebody can go, oh, I actually have that on a plan, or a broker that's like, I've got a client with that. So in a situation like that, where we trigger and go, okay, we've got a person with rheumatoid arthritis. They're on Humira, which is an ongoing cost of maybe $80,000 a year, $100,000? Easily for the medication itself. So where does the medical SWAT team kick in? Like, how would I engage Curus?
Usually with that particular client, the earlier we get involved, the better.
Okay.
But we'll get involved anytime, and we get in there, make sure that it's the right diagnosis, that they've got a second opinion, that they're on the correct medication. We could go down that rabbit hole, but I don't think we have enough time today.
Okay, fair enough.
But we're never going to say, oh, you got a bad doctor. And we're never going to say, oh, well, that medication's all wrong for you. But we will give, let's go back to your doctor and say, this drug might not be the best for your genetic type or for your multiple comorbidities that you have. And did they think about the other drugs that you're on? Whole person concept. Because some of these newer drugs, they counteract the other drugs that you need to be on. If that makes sense.
Yeah.
Trying to keep it simple. But so we look at all that, and we do have a pharmacist on staff that will help us guide that member. Now let's go back to a cancer diagnosis, right? That is more of a SWAT team analysis, because we get in there, we find out what cancer it was, what the staging is, what's been done so far. Do they need radiation? Can they go on a immunotherapy drug right away? And then we rally around them, answer all their questions, get them to their appointments. We make their appointments. We remind them of their appointment. And then not only that, we'll sit and talk with them, almost like what we're doing here. We get to know them intimately, and we help them make a list of talking points with that oncologist or that, whoever they're going to go see. And that is very, very rewarding.
Well, how do you get triggered to intervene in the first place? Does the employer have to notify Curus? How do they even let the member know that this service is available? Like, I want to hear about that communication piece a little bit. So
there's many ways.
Okay.
Sometimes it's word of mouth. Hey, we got this company. You got to get them for your son. Our typical way of advertising is through benefit advisors. Mm-hmm. For self-insured. We do have fully insured clients as well. We'll work with anybody. We're agnostic, but and then they know, hey, wait a minute. Yep, I remember now. Curus is here for that 5%, mm-hmm. and we already went through the diagnoses. But we'll do any case, but they've got to know about it, and that's why.
And that's always a difficult thing, right? And you're sort of at arm's length, or you're sort of dependent upon consultant and or perhaps the director mm-hmm. of HR, the head of HR, to be communicating to the population, just reminding people that this solution is out there. Because it's not like if I don't have a condition and 9 months in a plan, you're all of a sudden get diagnosed with something that's pretty traumatic. I'm not thinking about Curus on a daily basis, right? So how do you continually stay top of mind so people know that this service is there? Is that the $1 billion question?
That's why I'm here today.
Yeah. You go on podcasts and you talk about the service.
That's right. Yeah. No, it's us marketing ourselves and just we have to sell constantly. Yeah. And because we are a small niche company, it's really tough to do that. But we belong to like the UBA Association and other associations.
The United Benefit Advisors, brokers. Yeah.
Mm-hmm.
Yeah.
And so we try to primarily go through brokers. And our next model is going to be directly to employers. Directly to employers.
Mm-hmm. And does this something that has to be in motion at the beginning of a plan year? Does it have to coincide with the policy period or
No.
No? Okay.
No, we'll take any client anytime. We don't fall under ERISA laws.
Okay.
Because we're not in the benefit package. So any time during the year.
So, and then it's because I'm trying to think about if that were 8 months in a plan year, like I was describing earlier, 9 mm-hmm. months, trigger diagnosis, heard about Curus, boom, get in touch. There's a case rate, just a standard case rate, like you said. Mm-hmm. And so obviously that fee would be paid concurrently or prior to engagement. But then you're just off and running, right? Mm-hmm. I mean, that's really the only final check, if you will, before you get started. And so these things could be ongoing, right, too, as well, where you might be doing this throughout the plan year with multiple folks on a plan as well, right?
That's what's happening right now.
That's what's happening right now, because I don't think your job is ever technically done, right? We haven't fixed healthcare.
Right.
Right. Yeah. But what got you? I want to go back in your chronology, if you will. I forgot to ask this, but what drew you into this space? What interested you in clinical nursing in the first place? I'd like to hear that story.
Like as a young kid.
Yeah, as a young man.
I was always fascinated with science and anything to do with health. I don't know why. Just it was my thing.
Yeah.
And then I was always fascinated, and still am, with aviation. So to become a flight nurse was like awesome, you know. And I just was, and my mom had worked in an ER. She was an admin clerk, and I used to go in with her every so often, and that was like a really cool environment for me. And it just stuck, and I was like, I'm going to be a nurse.
And so and then
call it a calling. I don't know.
I mean, you just knew, right? But the experience that you developed through the course of what 20 plus years doing this, right? And you being prepared for a position like this, where it's like you're now getting to be involved in the U.S. healthcare system in the private setting, which is in massive need of overhaul. But I always love figuring out where each individual person's mission, because it's a humongous sector. There's so many moving parts. There's millions upon millions of people that work in it, hundreds of millions of people that are subject to it. Mm-hmm. So none of us are going to fix it on our own.
But that's part of the problem, though, isn't it? Having too many people involved. It's like uncontrolled bureaucracy.
Yeah, a little bit. Yeah. It's almost outgrown our ability to wrangle it in, right? And
That's
so
where the culture of apathy has come from.
You think so? Yeah. Okay. Right, but then you have to sort of pick what is my sliver of this system that I'm going to go set out to solve. Yeah.
And it goes back to why I became a clinical nurse specialist. It's about health outcomes.
Well, so what do you think the big picture then as we zoom out? Anything that you feel like we didn't cover on Curus though before we kind of proceed to the kind of the future state of this? Because I want to make sure if there's anything I forgot to sort of trigger or ask. This is such a new space for me. I almost sometimes don't know ultimately what are the things to ask.
We were talking about this over coffee. I think one thing that's important, going back to HR and union reps, and these people love us because, we had one lady tell us the other week, I get 11 calls a week from this employee. And since we hired you, I haven't heard from them, And so we take the burden off their shoulders too. And then we turn around and give them the outcomes.
Yeah.
Not personal health information, but, kept them out of the hospital. They're doing better.
Yeah, you're almost like noise canceling headphones a little bit from the HR department.
So we really are an add-on benefit to every part of the insurance world.
Yeah. Well, do you ever go into, maybe it's still early, but go into these advisors and sort of put together programs, because this is deliverable across any broker's block of business, right, or any agency's block of business. I mean, the only downside is whether or not somebody feels they can bear the brunt of the costs, and we don't have to get into what that cost actually is. But it's, this is something that doesn't really have, why would you not do it, other than perhaps the employer doesn't feel like they have the means to do it, or isn't perhaps as paternal as some other employers are.
Right.
But it's very clear, at least in the hearing you tell the story of it, that there's immense value there. And especially if I'm the member that's receiving the care coordination that you guys are providing. Yep. Yeah. So are there any common objections to it outside of money? And maybe that may not even be a common objection.
Well, that's a great question. It's twofold right now. Again, name recognition. Do they even know who we are? Do we exist? But even the clients that we have now, they're very hesitant in today's economy to hire anything extra.
Yeah.
Even though we more than pay for ourselves in the first 3 months. So that's the big roadblock.
That's a big, well,
the economy.
This has got to be something that's scalable. And let's kind of zoom out into the big picture of healthcare, right? It's like, how would you scale this? Because it's still going to be requiring human beings, obviously, to intervene.
Definitely.
To be there. There's only so many, I would presume, that have your level of expertise in clinical nursing and things like that as a clinical nursing specialist. So, like, is this a scalable thing, or will it always be kind of this SWAT team that only really comes in on an as-needed basis for those 5%?
We're currently scaling right now.
Okay, yeah.
So, it's definitely scalable.
Okay.
What I like to concentrate on is our clinical leadership.
Okay. How so?
Well, so the doctor, nurse practitioners, PAs, but we have hundreds of nurses that are our actual clinical team, if that makes sense.
Yeah.
So, we're definitely scalable.
Okay.
Like I said, we're in the process of scaling now, and we're going in some pretty cool directions with health data and, risk
Chat
assessment.
GPT, maybe a little bit. Yeah. We'll see how that comes into the framework.
Right.
But like, where do you see? You've been within. You have a unique perspective, I think, being in the military system from a nurse perspective. Mm-hmm. You've dealt with healthcare overseas, here in the VA system, and things like that. So, if you were to weigh in on your perspective with that experience that you've gained, like the bigger picture of healthcare, do you think this is going to be more of a private sector solution? Do you think there's a role to play with the public sector, or maybe a single payer, a hybrid of those? I never really ask people to weigh in politically, but how do we solve this at scale? And I'm not just talking about the 5%, right?
So the first thing that comes to mind is we got to quit making it a punitive culture for the healthcare providers.
Okay.
Nurses, technicians, doctors. Because everybody's doing extra steps just to cover the insurance policy, if you will.
I see.
You know what I mean?
Yeah.
And if there's a small error or something, it shouldn't be the end of somebody's career. And then that also adds to a lot of the health problems we have.
Okay. You think the potential for like malpractice suits and things like that is...
Well, definitely, that's part of it. But
are
usually it's the internal punitive system.
Oh, really? Okay.
Right.
Yeah, and outside of that, though, like, do you think that... is the VA model, is that convertible to the masses, if you will, because that's kind of a government run, if you will, but with a specific subset of the population.
Such a smaller population,
Yeah,
right?
yeah.
So, sure, I think there's lessons that can be learned on both ways. Like, for example, the VA recently allowed the vets to go downtown to get care. We call it downtown, civilian, and they cover it. And whereas before it was very rare that happened. So there's lessons to be learned for both systems, but I don't think that the VA system is viable for the whole.
You don't think so? Okay.
Nation.
Yeah. No, there's no wrong answer to this.
That's like saying everybody's going to have the same health care as a congressman gets.
Yeah.
It's just,
well, that's like saying like the direct primary care model. I talk about that all the time, right? And the challenges it has is just geography, right? And so is that scalable for the entire population? Maybe. It would take a long time likely to do that. So we have to look at models that also have a virtual care component, that have a hybrid component where there's a mixture, value-based care as well. Because I'm interested in the big picture of this.
Yeah, me too.
Yeah, you too. Yeah.
Even though we swoop down and micro target, but we're thinking big picture.
Yeah.
As well.
And so why don't we do this, Jared? I mean, you and I probably talked for about 45 minutes or so, and I want to kind of leave the floor to you as we close this thing out. What are some thoughts that you want to weigh in and leave the audience with of either your perspective or opinions you'd like to share? Really, the floor is yours to help us close this thing out.
Yeah, we are here. Curus is here to help support every business, all the employers, because it's tough when you get an employee. And many companies now are only one person deep in their shop.
Okay.
Used to be there were 10 or 20 people turning widgets or whatever, right? Now it's one person, and you lose that person, and the company's going to hurt in costs. They're going to hurt in their production and morale. Yeah. So that's another selling point. But this is a type of company where, like I said, we got to get the name out. And people need to know about us. And usually we have a company that will hire us for like one or two of their adverse select, and then they come back and here's 10 more. Yeah. They see the value in it. Yeah, because it's almost you have to get the opportunity to get in and prove it, right? Prove the concept first, right? And that's fair, right? Yeah, that's fair, right? Put me up to the test. Let's do this. Put me in, coach. Let me give you an at bat. Yeah, that's right. Well, Jared, I appreciate you coming in, and thanks for. I'm sorry about all the troubles you had coming in from Ohio, and we'll blame it on Chicago, right? Well, they're the ones that had the bad weather that you couldn't land. Anyways, I won't blame that. I learned a long time ago, if I can't do anything about it, don't stress. Don't stress about it. That's a good perspective to have. Yeah. Well, again, thanks for coming in, man. Thank you for educating me on this space. I imagine this won't be the last time we talk, and I'm hopeful that the clinical care coordination or clinical care orchestration. There you go. We'll get some inbound interest from what you guys are doing. But again, thanks for highlighting Curus Health, and appreciate the travel, man. Thank you. All right, my pleasure. Bye.